Yes, I can hear you.
So I didn't even open. We are in page
8.
8.
This one is new, isn't it?
Is what do you mean?
The peds 8 was not present in the old CMS. The link what I have given you, it was not present there.
I don't remember. I think so. I don't remember.
Okay.
Do you got it? Okay.
Yes, yes.
Got it. Okay. Ready.
Okay, wait. A 2-year-old girl is brought to the A 2-year-old girl is brought to the office by her mother for a follow-up examination 5 days ago. She completed a 10-day course of amoxicillin for acute otitis media. She has had 3 episodes of otitis media during the past year. She is not allergic to medications. Immunizations are up to date. Growth and development are appropriate for age. On examination, the tympanic membrane are pearly gray and retracted. There is decreased mobility bilaterally. Which of the following is the most appropriate next step in the management?
Ready.
Ready?
Mm-hmm.
Okay.
So it's no management indicated at this time. Otitis media with effusion is suggested by the presence of a middle ear effusion in the absence of um, signs of acute otitis media. Eustachian tube obstruction or dysfunction leads to accumulation of serous fluid within the middle ear. Such dysfunction is common in the setting of upper respiratory tract infection due to the inflammation of the nasal mucosa, mm, including the osteum and of the eustachian tube, or as a sequela following acute otitis media. Fluid accumulation typically presents with hearing loss, ear tugging, vertigo. Patients with otitis media with effusion lack findings of fever, tympanic membrane redness, tympanic pulse, which are commonly found in acute otitis media. Treatment is supportive as the condition is self-limited. It's not to be amoxicillin therapy and self-denial therapy are unhelpful in the setting of otitis media with effusion, which occurs due to a station top dysfunction rather than active bacterial infection. Okay, next.
A 6-year-old girl is brought to the A 6-year-old girl is brought to the office by her mother because of compulsive eating since the age 3 years. He was born following an uncomplicated pregnancy, and delivery was complicated by breech presentation during infancy. The patient had hypotonia. She began walking at the age of 2 years and talking at the age of 2.5 years. The patient lives with her mother and older sister. She is at 52 percentile for height, 98 percentile for weight. Her temperature is 98, pulse 92, respiration 20 per minute, blood pressure 86/50. Physical examination show almond-shaped eye and a prominent almond-shaped eye, prominent nasal breeze. There is hypotonia. Mental status examination showed delayed speech and motor development. Which of the following is Most likely diagnosis.
Oh, Jesus. In case the almond chip pie and the need to eat. Was it stop Prader Willie? Was it Angelman? Or was it Williams syndrome? Maybe William. I'm not sure on this one. Ready?
Hyperphagia comes with Prader.
Right.
I
But
think
Prader is
so. Prader
but
has,
Prader
yes.
isn't also the happy baby, the one that laughs all the time.
Happy puppet. Yes.
Happy puppet is the Prader.
I think that Angelman is happy puppet.
Oh, it's Angelman that's happy puppet.
But
Okay.
Prader has hyperphagia.
No, okay, it's probably Prader. Yeah, it's Prader-Willi. Prader-Willi syndrome is a rare genetic disease caused by lack of expression of paternal Prader-Willi, lack of expression of
Mhm.
paternal genes in the chromosome region 15q1113. Paternal genes. It is inherited in a sporadic pattern and may result from mutations or deletions in the paternal gene, errors in the genetic imprinting of these alleles, or the complete absence in the case of maternal and parental trisomy. The syndrome has several characteristic features. Hypotonia is common and can lead to abnormal uterine position of the fetus and complicated labor, as well as feeding difficulties and failure to thrive. Development delays, intellectual disability, and disruptive behavioral patterns are commonly observed. It's associated with growth hormone deficiency and short status. Hyperphagia and obesity are also hallmark manifestation of Prader-Willi. Individuals tend to have distinct faces with almond-shaped eyes, strabismus, and a wide, flattened nasal bridge. Prognosis is good as patients tend to do well in adulthood. Angelman, um, similar genetic disorder caused by loss of expression of maternal gene UB3A, which is also found in chromosome 15. The key feature that distinguish it from Prader-Willi include hyperactivity, excitability, uncontrolled laughter, sleep disorders, and puppet-like ataxia. Hence, flapping is characteristic. And German is okay. And it's not Williams syndrome, characterized by distinct health-like faces, verbal and social skills that often mask intellectual disabilities, and an extremely friendly demeanor. Supravalvular aortic stenosis is common. It results from microdeletion on chromosome 7 that includes elastin gene. Okay.
So Prader-Willi is happy puppet, isn't it?
No,
Uh,
no.
uh,
Really,
sorry.
no.
Angelman is happy puppet. Hyperactivity,
Angel,
uncontrolled laughter, sleep disorder, puppet-like ataxia. And Prader is,
like the fat baby, I guess.
yes,
And then Williams syndrome is the elf faces.
faces, verbal, social skills.
Wait, what was anorexia again? Was it less than 18.5 or 17.5?
I think that's 17.5.
Different. Okay. Never mind. Get, okay.
Okay.
And the high BMI will be more than 30, right? On the questions. Or would it be more than 25?
More than 30 usually, but there
More
is
than,
an indication where we need to do surgery, like
okay.
bariatric surgery. It is, I think that it
Oh,
is more than 35.
more than 30. Okay. Got it. More than
So
30.
that thing we need to remember.
Okay. Got it. Got it. I was, I like one girl posted she took her step two yesterday. You know what? I don't know who turned the notifications on my Reddit on my phone. So every time somebody posts now, it's just like ping, ping, ping. My phone is like I don't I don't know how it happened, but I need to figure out how to turn it off on my phone.
Yeah,
But
you
yeah,
can turn it off. It is easy. Initially, I
I'm
saw
like,
that
wait,
post, but it made me
yeah.
scared, so I stopped seeing that.
Yeah, because right now it's like I beep 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 beep. So I put it on vibration, but it's still like it will vibrate when you know. And some girl posted like that she took the exam yesterday, and she was like, "Guys, just focus on." She was like, "Ethics, just guys focus on ethics because it's."
How people can focus on ethics? I don't know.
I don't know.
You
She was like, "No,
you
oh no." Somebody asked him because oh, he's right here. Somebody asked her what was the most tested topic. That's what happened. And then she said ethics, then next best antibiotic, and then next best step in management and vaccines.
so they
So
that fourth thing we actually read very less.
the what?
These four things actually we read very less.
Because it's not like no, we do a lot of next best step. We do. And we do a lot. This CMS have a lot of vaccines. Like I don't feel like you had a lot of vaccine questions, but this CMS had a lot of vaccine.
But we need to read the that vaccine schedule or USTPF or
Yeah,
something like that. We need to like go it thoroughly, like from first to last. Do
like
you
as
have,
for
sorry,
I can read that vaccine how many times, but if I don't do, I'll forget. Mostly the years when it's like, from 16 to blah blah blah. Like if I don't do questions,
after
I
doing like this CMS form, before starting the new CMS, we can do one day like people are telling about high yield 200. Is
the
it
ambush. Yeah, yeah.
that emboss high yield 200 questions?
Yeah, she said yeah. So somebody asked her, "What did you use for it?" Whatever. She said, "Yeah, I use Ambos, the high yield 200." I never
It,
opened Ambos, so I don't know how it is. But she says there is a ethics part, there is a quality improvement part, then there is like a 200 high yield, and but I never opened it, so I don't know how it's separated. I don't really know.
okay.
How they separate that. But I definitely I was going to do that either way. But I think we touching everything like the next step in management. We are doing a lot of those questions. Next best antibiotic. I don't know what that means. I'm thinking she means like next best like drug. That like I don't think that's
Next
what
base
we are.
antibiotic, if you think about like otitis media, the
Yeah.
first step is amoxicillin.
Yeah.
Then the next is amoxicillin clavulanic acid. If the person is penicillin allergic, then uh, there is another antibiotic. Like this type of
Yeah.
questions.
And we've been doing.
But
I think that we've been doing.
this type of question actually touches the step three.
Oh.
You got my point. Like in the step three question, actually, this type of version is present
Oh.
because in the step three they actually deal with the treatment, because after that you have to go for treatment, isn't it?
Mm, but isn't it the next? I'm thinking when she said next best antibiotic, she's talking about the treatment. When they ask what's the treatment for, I'm thinking this is what she means. Because if it's specifically antibiotic, then it's like micro. Then it's I don't know. I'm thinking that's what she meant. So we've touched on that a lot. The vaccines, I feel like
In the world, infectious disease is very superficial.
it is kind of yeah.
But according to the according to the Reddit, the
Hmm.
NBME 15 is full of microbiology.
Oh really?
Yes, they are one. I have seen one or two posts that it
Mm.
is actually based on full of microbiology. If it is full of
Oh,
microbiology, then you need to like read the first aid or sketchy
oh.
ones before
Then that's
jumping
what she
into.
does. Then she probably does mean next best antibiotic specifically. Like she doesn't. Yeah, she
But
probably does.
if you go through these two thing, you will not gonna find the best antibiotic, because like in the uh, sketchy, they told in the staff vancomycin, the van one, but
Mm-hmm.
actually not always we give vancomycin.
Yes, yes, yes. Okay,
So
so I feel like definitely next best step in management, antibiotics and vaccines. We are touching it more in CMS. Like I feel like your word was
yes,
not really the best on those, like emphasizing those. But CMS, it has a lot of like antibiotics and vaccine. What's the best vaccine for the person right now, and it does. So okay, I mean, at least we're doing okay. And ethics, we done ethics in New World, so I feel like ethics we were a little bit. It wasn't that bad. I mean,
I'm bad at ethics. Okay. I am unethical. Okay.
you're an ethics.
Okay. a Sorry. 5 minutes after delivery, a full term shows peripheral cyanosis, decreased muscle tone, peripheral cyanosis, occur, and decreased muscle tone, decreased reflex, and pulse is 80 per minute, and respiration is irregular. Which of the following is the most likely Apgar score? Apgar score, AFPGAR, Apgar, isn't it? Appearance,
AP. Uh-huh.
appearance, cyanosis, peripheral cyanosis.
Mm.
Then one, muscle one.
Decrease muscle tone, decrease reflex. I think each one is like 2 points, 2 points, or is it
Yes,
1.1?
each one has 0, 1, and 2 point. There is 0 point also. If
Zero,
there is
one.
absent reflex, I think that's 0. If there is absent tone, I think that it
Okay.
is 0. Probably.
Okay. Here
I
is
think that
yeah.
it is okay.
So here is decrease. It's not absent. So it's probably one. Then one, one, two peripheral cyanosis. So it's probably between
4 to 6.
4 to 6. Yeah, makes sense. Not makes sense, but yeah, I guess. Okay, answer is 4 to 6. Apgar score is performed at 1 and 5 minutes after birth to assess the status of the newborn and need for possible resuscitation. Okay, the Apgar score consists of points given in 5 different categories: appearance, pose. Oh, so it stands for the name. I never knew that.
Yes.
Appearance, pose, grimace or reflex,
Activity
grimace or
and then
irritability.
reflex. Activity. Activity is the muscle tone.
No, it says grimace or reflex, then
Okay, okay.
activity or
Oh,
muscle
yes.
tone, and then respiratory. So it's appearance, A. P, pulse. G, grimace or reflex. A, activity or muscle tone. And then the next R, irregular, respiratory.
Respiratory.
Sum together to complete the ABGAR score. Each category is given 0, 1, 2 points, with 0 points being absent functions or no at all. 1 for diminished or irregular function, and 2 for normal expected presentation. So it will be 4, 6, 8, 10. Okay. Newborns with lower score, especially below 7, may require further evaluation and intervention. This patient will receive a score of 1 for peripheral cyanosis, so that will be appearance. 1 for decreased muscle tone, that would be activity and muscle tone. 1 for decreased reflex activity. 1 for pulse less than 100, and 1 for irregular respiration. Okay. Totaling an APGAR score of 5. This indicates the potential need for further resuscitation. APGAR scores are not necessarily associated with later function and developmental abnormalities. Okay. We never knew that. Okay. Oh, I checked the CMS. It says that if you get between like 10 to 15 mistakes, you are like in the 240s and plus. That's the only thing that I kind of
Okay, you are doing 10 to 15 mistakes.
mistakes. If you are between 10 to 15, then that means you are around like 240 plus scoring. That's the only thing I
That,
found.
that's good.
That's good. I'm not scoring 10 to 15. So
No, no, you are very good. All
so
you have to All you
I'm
have
not.
to do is to self-believe that you can get it, inshallah.
Mm,
For
it
my
is.
case, it should be reverse. Okay. If you differentiate the Prader-Willi and the Angelman,
Mm-hmm.
Prader-Willi has paternal microdeletion and Angelman has maternal microdeletion. And Prader-Willi has, but Prader-Willi has, we know that Prader has no papa, so paternal microdeletion and maternal unipaternal diasomy. Okay, and if you look at the clinical feature, like there is neonatal hypotonia, hyperphagia, obesity, hypogonadism, developmental delay, and intellectual disability. But in Angelman, it is ataxia, seizures, inappropriate laughter, smiling. Okay, okay, next. An asymptomatic 14-year-old boy is brought for a well child examination. He has had a murmur since 4 years of age. A grade 2 by 6 aortic systolic ejection murmur and grade 1 by 6 early diastolic murmur, and the mid left sternal border are hard. Echocardiography shows bicuspid aortic valve. Echocardiography shows bicuspid aortic valve uh, with mild with mild gradient. For which of the following conditions for which of the following condition in this patient is for which of the following patients for which of the following condition in this patient at greatest risk during childhood? Injection, bypass.
Ready?
Yes,
So it is bacterial endocarditis. Bicuspid aortic valves may be inherited or sporadic. The result of their geometry and abnormal leaflet excursion, they are subject to more blood flow turbulence, generating of murmur and shear forces. This leads to increased local tissue inflammation and calcification, compared with tri-leaflet valves. Bicuspid valves are more prone to the development of early aortic stenosis and aortic regurg. Abnormal valve architecture can also present as a needles for infection, hence patients are at increased risk for bacterial endocarditis. There is a small, there is also a small risk for systemic thromboembolic disease from clots that form on the valve. Congenital and hereditary conditions. One moment, I have to answer this phone call. I'll call you
yes,
while you wait.
yes, obviously.
Needles for infection, hence patients are at increased risk for bacterial endocarditis. There is also small risk of systemic thromboembolic disease from clots that form on the valve, congenital and hereditary conditions associated with bicuspid aortic valve include sternum, Marfan, eldest, and loss coarctation of the aorta, patent ductus arterius too. NVSDs. It is not syncope. Where is it? Syncope may result from one of the conditions associated with bicuspid aortic valve, such as advanced heart failure, but it's not directly correlated. It's not a directly correlated risk. Okay.
Okay, next. A 2-year-old boy is brought to the physician. A 2-year-old boy is brought to the physician because of 2-day history of fever and mouth sore. Her mother says that she has been fuzzy and refused to eat, but that he is beginning to feel better. He has 1 year history of similar episodes that occur every 3 weeks, last for 3 to 5 days. Growth and development are appropriate for age. Temperature is 101.2 degree Fahrenheit, pulse 120 per minute, respiration 20 per minute. Examination shows aphthous ulcer, scattered aphthous ulcer in the oral cavity. The skin is clear. There is no lymphadenopathy. Hemoglobin 11.5, leukocyte 4000, segmented neutrophil 4%, lymphocyte 84%, monocyte 12%, platelet count 2,50,000. Which of the following is the most likely diagnosis?
Source. Fever. Lymphadenopathic and chronic hypersplenism and leukemia. Congenital
Yes,
neutropenia.
recurrent abscess.
Viral illness. Jesus. You gave so many options. Cyclic neutropenia. Okay, ready?
Ready.
So it is cyclic neutropenia. I knew that shit. Cyclic neutropenia. Cyclic neutropenia, rare inherited immunodeficiency syndrome,
I heard
characterized,
for the first time.
characterized by periodic episodes of neutropenia and infection. Most cases follow a cyclic pattern that occurs okay, that's why it's cyclic, every 21 days and typically lasts for 3 to 6 days. Classic symptoms include fever, malaise, ulcers affecting the oral mucous membrane. Some patients may also develop pharyngitis and chronic periodontal disease that can result in early tooth loss. During episodes of neutropenia, patients are at increased risk for bacterial infections that may involve the respiratory, GI tract, urinary tract, or skin. Pathophys is not well understood. However, the disease is associated with mutations in the gene encoding neutrophil elastase. The diagnosis can be confirmed by monitoring a patient's neutrophil count several times weekly for at least 6 weeks. Genetic testing for mutations in the neutrophil elastase gene is also recommended. Acute management involves treatment of the current infection with appropriate therapies and maintaining good oral dental hygiene. Long-term therapy with human granulocyte colony stimulating factors is effective in keeping neutrophils at normal concentrations in the blood. Snashiga-Kitashi syndrome, caused by mutations of the lysosomal trafficking regulator gene, list essential for normal formation and transportation of lysosome within the cell. It presents with frequent bacterial infections, oculocutaneous albinism, peripheral neuropathy, and progressive neurologic function. It's not Dick's keratosis congenita, rare genetic condition associated with bone marrow failure. It's characterized by triad of skin abnormalities such as reticular hyperpigmentation pattern, pale gray macules, areas of atrophy, dystrophic nails, and oral leukoplakia. Patients will have pancytopenia. So bone marrow failure, skin abnormalities, problems with nail and oral leukoplakia. It's not Fanconi syndrome can be inherited or acquired that causes malabsorption of solids in the renal proximal tubule. Fanconi anemia, however, is a separate condition that causes bone marrow suppression. Pancytopenia, a recurrent infections. It is also characterized by short stature, microcephaly, and developmental delay and cafe skin regions. It is not. What was I supposed? Oh, hypersplenism can have multiple causes, but commonly involves splenomegaly and cytopenias of all three cell lines, varying degrees as a result of sequestration cells in platelets. Sequestration of circulating cells in platelets. This patient periodic episode and isolated neutropenia. No. Leukemia, especially ALL, is common in pediatric malignancy, and B and T cells that may present with malaise, fatigue, weight loss, splenomegaly, lymphadenopathy, anemia, thrombocytopenia with circulating blood cells. Severe congenital neutropenia is another congenital disorder characterized by low concentration of circulating neutrophils and recurrent bacterial infections. In comparison to cyclic neutropenia, severe congenital neutropenia is typically more severe and presents with infection in the first few months of life. It has a high risk for transformation into AML. Okay.
So severe congenital neutropenia can be transformed into AML.
Yeah, and it's in the first months of life. So this guy is 2 years old. So no.
So it is cyclic.
Mhm. Okay. Next.
A 6 year old girl. Previously, the 6 year old girl is brought to the physician in June because of 4 day history of persistent fever, 4 day history of persistent fever and severe headache, a 1 day history of rash over the hands. She lives in a rural area and is frequently she lives in a rural area and is frequently bitten by mosquito. 1 month ago she was treated with 1 month ago she was treated with corticosteroid for poison ivy. She appears ill. Her temperature is 39 degrees Celsius, 100.2 degree Fahrenheit. Pulse is 110 per minute. Respiration is 22 per minute. Examination shows bilateral non-purulent conjunctival injection. Scattered petechial lesion over the palms and the distal aspect of the upper extremity. Which of the following is the most likely diagnosis? Bilateral non-
Mm. The Rocky Mountains spotted fever, bitten by mosquitoes. Ready?
Yes.
Okay. So it is Rocky Mountain spotted fever. Oh, suck at this. Rocky Mountain spotted fever. Let me read it from here. Is a tick-borne disease caused by Rickettsia rickettsiae, which is a gram-negative obligate intracellular organism. This organism target endothelial cells, triggering vascular injury and permeability. This illness is most common in the early spring and summer, following a tick bite in an endemic area like mid-Atlantic Southeast US. Incubation occurs 2 to 14 days after exposure, and manifestation include fever, headache, and petechial rash. Other manifestations include conjunctivitis, seizures, encephalitis, ARDS, cardiac arrhythmias, coagulopathy. Lab testing shows thrombocytopenia, um, hyponatremia, increased liver enzymes, increased PT, and like PTT and PT, I guess. No, partial thromboplastin and prothrombin types. If there are concerns of central CNS involvement, lumbar puncture is recommended. Serologic testing for IgM and IgG antibodies against rickettsia is the most used test, and patients are most often treated with doxycycline therapy. In general, patients have a rapid response to therapy. Empiric treatment should be initiated when clinical suspicion is high, as early treatment improves the prognosis. And lab assays are not perfectly sensitive and specific. It's not dengue fever, presents with febrile illness with associated headache, retroorbital pain, and marked bone and muscle pain. Okay, muscle pain. Symptoms last approximately 1 week and patients may develop hemorrhagic complications. Dengue is transmitted by Aedes mosquitoes in tropical and subtropical climates. This patient presentation is not consistent with dengue and is not exanthema subitum or rheozola infantum. Mm. It's
Dengue is
caused by
very common in our country, very alike endemic.
oh,
So
oh.
both dengue and COVID-19
Hmm.
is has become a talk of the town in our country.
Rosiola is caused by HHV6 infection associated with several days of fever, sometimes accompanied by seizures. As the fever stops, a characteristic blanching macular eruption forms on the neck and trunk, which then spreads to the face and extremities. The characteristic high fever followed by a rash helps to diagnose Roseola infantil, whatever, as the cause. Treatment is supportive. Okay.
Okay, next. A 4-year-old boy is brought to the office for a well child visit. He can imitate a straight line. He cannot copy a circle. He combines words and only half of his speech can be understood. He can jump but cannot balance on one foot. Physical examination shows no abnormality. Which of the following is the most accurate assessment of this patient's development?
Jesus Christ.
Mm, gee, fine, show the data.
Ready?
Yes.
How we got this one? Hey, everything is delayed. Jesus. Screening for developmental milestone achievement is an important element of the pediatric well child exam. Gross fine motor, cognitive, social, and language milestones should be evaluated. This patient has a presentation consistent with global developmental delay, defined as significant delay in two or more domains of development. By age 4, most children can draw a stick figure, speak in full sentence that can be understood by others, hop on one foot, and play cooperatively with friends. Patients who are delay meeting developmental masters should be evaluated um, for underlying cause and refer for early childhood intervention where they can access speech therapists, physical therapists, occupational therapists who can work with them.
Okay. Next. Okay. Look at the picture and tell me your diagnosis.
I think we did this question yesterday, didn't we? Is it
Is it
cytomegalo?
cytomegalo, periventricular?
That's what I'm thinking.
Let's see. Just not reading the question.
Yes, it's cytomegalovirus. It's the exact same picture.
Okay, then we can skip. You
Okay.
want me to read the? I think that it is almost the same pattern of the question.
Okay.
Next,
Oh, can you read the toxoplasma too?
the answer.
Yeah, toxoplasma and the educational objective.
Okay, Toxoplasma gondii is an apicomplexion that may be acquired through transplacental infection. Congenital toxoplasmosis presents with classic triad of chorioretinitis, hydrocephalus, and intracranial calcification, which have a ring enhancing appearance. The absence of hydrocephalus and the presence of periventricular calcification is more consistent with congenital CMV infection. So Toxoplasma gondii has intracranial calcification and ring enhancing lesion, multiple ring enhancing lesion. Okay, congenital cytomegalovirus infection with intrauterine growth restriction, microcephaly, intracranial calcification, hearing loss, seizures, hepatosplenomegaly, jaundice, thrombocytopenia, petechial rash. A primary maternal infection has a high risk of vertical transmission via placenta to the fetus. Intracranial calcification have a characteristic periventricular distribution may have detected by ultrasonography or CT scan. Okay, next. A 3-month-old boy is brought to the emergency department because of 3-day history of pale complexion, low-grade fever, vomiting, occasional diarrhea, poor feeding. On arrival, he appears mildly dehydrated and cyanotic. His temperature is 100 degree Fahrenheit, pulse is 165 per minute, respiration 35 per minute, blood pressure 80 by 40, blood pressure 80 by 40, respiration 35, blood pressure. Pulse oximetry on the room air uh, shows an oxygen saturation 85%, a grade 3 by 6, harsh systolic, ejection murmur is heard over the entire pericardium, perfusion and muscle tone are normal. During attempt to insert an IV catheter, the patient begins to cry and becomes agitated. His oxygen saturation decreases to 60%. The murmur barely audible. Supplemental oxygen is administered. Which of the following is the most likely diagnosis?
Not over the entire pericardium. Let me see. Think. Tetralogy is 3 months.
Oxygen saturation is very low. Decreases 60%. Murmurs. Sub.
Uh, Ready? I'm lost on this one.
Okay.
So it is tetralogy of Fallot. Tetralogy of Fallot is the most likely diagnosis in this patient with paroxysmal cyanosis during crying spells, and 3 out of 6 systolic ejection murmur on exam. Tetralogy of Fallot consists of pulmonary infundibular stenosis, overriding of the aorta, VSTs and right ventricular hypertrophy, resulting in a right to left shunt with cyanosis first noted in infancy. Right ventricular outflow tract obstruction eventually leads to right ventricular hypertrophy. The murmur heard with etiology of Fallot, which is typically a systolic best heard in the lower sternal, left lower sternal border, is caused by right ventricular outlet obstruction, not as often by the VSD. Paroxysmal cyanosis that occurs during periods of crying is a classic presentation, and these episodes are referred to as death spell. Patients during one of these spells often exhibit rapid deep breathing, agitation, and progressive cyanosis. These periods of cyanosis occur as a result of transient obstruction or occlusion of the right ventricular outflow tract, leading to decreased blood flow through the pulmonary circulation. Although the cause of the underlying transient obstruction is unclear, treatment of tetralogy of Fallot is with surgical correction. Surgery aims to relieve right ventricular obstruction, close the VSD, and separate the pulmonary and systemic circulation. Surgery is usually performed in the first 6 months of life and almost always within a year. It is not. What was I confused again about? Murmur over the entire precordum with ASD and VSD. It's not ASD, it's a common congenital malformation of the interatrial septum that results in left to right shunt between the atria, mixing of oxygenated blood from the left atrium with the oxygenated returning from the superior vena cava results in higher oxygen concentration in the right atrium and ventricle than normal. Does not cause cyanosis. Usually a fixed split second heart zone. VSD refers to defect in interventricular septum. Most common, the membranous portion is characterized by holosystolic murmur. Best heard at the left lower sternum, but it doesn't cause cyanosis. Okay, next.
A 5-day-old Mediterranean descent is brought to the physician because of 2-day history of progressive jaundice. Had five yellow he has had 5 yellow CD stool during this period. He was born at term to a 32-year-old primary gravid woman. During the third trimester, his mother took an old prescription of sulfamethoxazole for cystitis. Without consulting the physician, the blood group of the mother and the newborn is ORH positive. He receives 2 ounces of cow's milk based on formula every 2 hours. Examination shows no abnormality except for jaundice from the head to the upper thighs. His hematocrit is 33%. Total serum bilirubin concentration is 20 mg per deciliter with a direct content of 0.9 mg per dl. Direct and indirect antiglobulin Coombs tests are negative. Which of the following is the most likely explanation for this patient's jaundice?
Between enzyme deficiency and physiologic jaundice. What enzyme he does not have?
Physiologic jaundice is just after birth, isn't it? This is
Mm,
5-day old. Oh, sorry. Physiologic jaundice is from third day to 10th day. Okay.
mm,
And the blood group of mother and okay, O positive. Both are O positive. So no ABO incompatibility.
Ready?
Okay.
Yeah, okay. So it is enzyme deficiency. Anyway. Neonatal jaundice is defined as an increased bilirubin more than 5 that results
Oh,
from either increased
we missed one important point. Total bilirubin concentration 20, direct is 0.9. So indirect hyperbilirubinemia.
uh, oops, okay.
Indirect
That is,
hyperbilirubinemia comes with the enzyme.
so physiologic jaundice, what kind of hyperbilirubin is it? Isn't it indirect too?
Sorry, physiologic jaundice is
Is that
high, yes, usually indirect hyperbilirubinemia. Yes.
okay? Neonatal jaundice is defined as increased bilirubin more than 5 that results from either increased hemolysis, bilirubin generation or decreased bilirubin conjugation or excretion. Hyperbilirubinemia can be divided into direct and indirect forms in which either conjugated or unconjugated bilirubin accumulate respectively. It can also be divided into physiologic and pathologic forms. This patient has anemia and an indirect unconjugated hyperbilirubinemia. Okay, that has presented in the first few days of life, suggesting a pathologic hemolytic process. The differential includes immune-mediated hemolysis, inherited erythrocyte membrane defects, and erythrocyte enzyme deficiencies. For this patient with a negative COMS test and Mediterranean background, the most likely cause of his unconjugated hyperbilirubinemia is deficiency of the enzyme G6PD. G6PD is an enzyme in erythrocyte that makes NADPH from NADP, and inadequate supply of NADPH leads to decreased concentration of glutathione, which is a critical scavenger of reactive oxygen species within erythrocytes, increased oxidative stress, which can occur with exposure to sulfur-containing compound, results in hemolysis. It's not physiologic jaundice. Physiologic jaundice occurs in nearly all newborns and is caused by increased breakdown of red blood cells, immature liver metabolism of bilirubin, and increase in hepatic circulation of bilirubin. Features include development. Features include development after 24 hours of life, a rate of bilirubin increase of less than 0.5 daily, maximum peak of 15 to 14 to 15, and a predominance of indirect bilirubin. In this patient, the increased bilirubin concentration to 20 and low hematocrit should prompt evaluation for pathologic causes. So for physiology, it shouldn't pass 15 for bilirubin.
Okay. Okay, let's take a break. Have you
You can be done with peds. I'm tired of peds. These are my worst. From all the CMS we've been doing, it's like I've been doing so bad in peds. It's crazy.
so you have finished psych.
I only have one inside the seven.
Okay. We can do it
Um,
together.
yeah, I
And
finished. We finished
uh,
OBG. We've
yes,
done that,
you have
and we
finished
had
internal medicine.
yeah, we finished. I did it with you. We finished internal medicine, and so we only have like we have two more for family, but we didn't have them. It's the new ones that you just sent.
We have
We
family medicine.
two.
Th-
We
and
only did two, and then
yes.
you sent two new ones. We only did two and three, and then you sent four and five.
Okay. And is there? Oh, have we done surgery?
No, we have not done no surgery. We have not done neuro, and we have not done emergency.
Okay.
But the emergency is only like two of them. Yeah.
Okay. A seven. Oh, okay. A 7-year-old boy is brought to the physician for a follow-up examination 3 weeks after nail punctured his right foot through his shoe. The wound was thoroughly cleaned and bandaged, but he continues to have moderate pain. But he continues to have moderate pain. The patient received the tetanus vaccine at age 5 years and is otherwise healthy. His temperature is 37.2. Vitals normal. Examination of the wound site shows erythema and warmth over the underlying skin with tenderness to palpation. Which of the following is the most likely causal organism?
If I don't get this one right, it's not good. Ready?
Yes.
So it's Pseudomonas. Osteomyelitis may occur from hematogenic spread from adjacent skin and soft tissues, infection, or direct inoculation into the in the case of trauma. Osteomyelitis clinically presents with pain at the site, redness, tenderness to palpation, swelling, decreased range of motion, and fever. Pseudomonas is an aerobic oxidase positive gram negative bacteria that is associated with hospital acquired infection as well as osteomyelitis following a puncture wound, classically to a shoe. Patients who suffer puncture wounds and diabetic patients uh, are at the highest risk for pseudomonas osteomyelitis. X-ray MRI may be used to identify osteomyelitis, although MRI is more sensitive. Patients should undergo operative debridement to remove necrotic tissue. Culture to identify the organism and be initiated on empiric antibiotic coverage is not Staph aureus. Is the most common cause of osteomyelitis. This may be related to direct inoculation or hematogenous spread, such as case of sepsis or IV drug use. Pseudomonas osteomyelitis is more common in puncture wounds. Okay, next. Go.
So, um, in case like how you reach that this is osteomyelitis,
Oh,
like puncture
when
wound.
no, once you say nail going through the shoe, whatever going through the shoe and causing osteomyelitis is pseudomonas. Just I don't know where I read it. I don't know if it's divine, but yeah, something going through the shoe is pseudomonas.
Okay. A 16-year-old girl is brought to the physician by her mother because she has not had menstrual period. She has no history of serious illness, takes no medication. She appears in no distress. She is 5 feet 7 inch tall and weighs 54 kg. BMI is 19 kg per meter square. Breast development is sexual maturity. Rating is stage 4. There is minimal axillary and pubic hair development. Pelvic examination shows normal external female genitalia. Pelvic examination shows normal external female genitalia. The cervix is not visible. No pelvic mass are palpable. Cervix is not visible. No pelvic mass are palpable. Which of the following is the most appropriate next step in the management? Cervix.
Ready?
Yes.
So it's karyotype analysis. Androgen insensitivity syndrome (AIS) is caused by defect in the androgen receptor complex, resulting in a genotype that's 46XY for male. The person developing phenotypic female or atypical genitalia and female sexual secondary sexual characteristics. Testes are present and produce testosterone normally, but the absence of a functional androgen receptor prevents hormone binding and thereby prevents the development of secondary male sexual characteristics. Patient presents with female external genitalia, skin, pubic and axillary hair, absent uterus and fallopian tubes, and rudimentary vagina. Menses do not occur because of lack of progesterone and estrogen and the lack of functional uterus with endometrial lining. Patients show increased concentration of testosterone and estrogen and LH or lab. Diagnosis is made with karyotype analysis showing 46XY chromosome in a patient that looks like a female. Next.
Yes. A 14-year-old girl is brought to the physician because of dark colored urine for 5 days and a facial rash for 1 day. She has a history of diffuse joint pain treated with acetaminophen. Blood pressure is 115 by 70. He appears pale and thin. Examination shows prominent erythematous butterfly-shaped maculo macular eruption over the face. Which of the following is the most Which of the following lab findings is most likely to be decreased? Is it SLE?
Probably. I think
Okay.
so. So, is C3 concentration. SLE autoimmune disorder with a wide range of presentations. Cutaneous manifestation include red rash over the mother cheeks that spread on nasolabial folds after sun exposure, discoid lesions with hyperpigmented edges and pink atrophic centers, painless oral ulcers, and non-specific hair loss may occur. Fatigue, joint pain, fever are also common. Lupus nephritis, a common complication, especially in younger patients. Younger women, patients with lupus nephritis typically present with evidence of active SLE and may additionally display oliguria and uria. Signs and symptoms of hypertension, headache, visual disturbance, uremia, fatigue, nausea, vomiting, pruritus, altered mental status, hyperkalemia, peak weighs on ECG, and hypervolemia with edema. Lupus nephritis involves glomerular deposition of antibodies, including IgG, IgM, IgA, as well as activation of the classical complement pathway. Lab studies therefore generally show hypercomplementemia with decreased serum concentration of early classical pathway components C1, C2, C3, C4, CH50. As well as increased creatinine. Kidney biopsy is useful for disease staging and may show a range of histologic patterns. From essential glomerulonephritis to diffuse proliferative of membranous glomerulonephritis. So, glomerulonephritis either way. Okay, next.
Okay. A 9-year-old boy is brought to the emergency department by paramedics 20 minutes after sudden onset severe shortness of breath after waking up off flight of steps. He has had similar episodes over the past 12 weeks. En route administration of 40% oxygen by face mask did not relieve his symptoms. He appears anxious and restless. His temperature is 37 degrees Celsius, pulse is 110 per minute, respiration 30 per minute, blood pressure 110 by 60. Faint expiratory wheezing is heard. Breath sounds are distant bilaterally. Examination: which of the following is most likely underlying mechanism of these patient which of the following is the most likely underlying mechanism of this patient's condition?
Pulmonary vascular resistance.
Wheezing, it sounded distant,
Hmm,
distant. Is
hydrostatic pressure. Hmm, pulmonary vascular resistance. in between D and E. Pulmonary capillary hydrostatic pressure.
Let's
One
also
second.
touch
Ready?
this. Hmm, okay,
Okay. So it is, oh my lord, activation of mast cells.
it is asthma.
I, yeah, I did not see that. This patient presenting symptoms, signs and symptoms of exertional induced wheezing, chest tightness, dyspnea, and cachypnea suggestive of asthma exacerbation. Asthma is characterized by the reversible obstruction or to airflow caused by spasm of smooth muscle in the bronchi and small airways. It's often triggered by an allergen, smoke, pollen, exercise, temperature change. It can cause, in the case of allergen-induced asthma, bronchoconstriction is triggered by IgE-mediated activation of mast cells, followed by degranulation and histamine release. Such mast cell activation is classified as type 1 hypersensitivity reaction. These reactions are composed of two phases, the immediate and the late phase. In the immediate phase, perform IgE on the surface of mast cells, and basophil is cross-linked by an antigen leading to the granulation and release of histamine, which results in vasodilation, vascular permeability, and bronchoconstriction, among other effects. The late phase occurs after the initial insult and is mediated by release of prostaglandins and leukotrienes synthesized by the mast cell. Um, okay. Treatment for asthma depends on the classification. Intermittent, mild, moderate, severe, persistent. In the case of exacerbations triggered by allergens, agents that act on mast cells or IgE may be employed. The prototypal mast cell stabilizer is cromolyn sodium, which prevents mast cell degranulation and the release of histamine and leukotriene. It is used in the treatment of asthma and exercise-induced bronchospasm. Another agent is omalizumab, monoclonal antibody against IgE, used to treat patients with asthma and increase IgE concentration. Not see that one. Increased pulmonary capillary static pressure described the pathophysiology of pulmonary edema. Increased hydrostatic pressure results in extravasation of fluid in the interstitial space of the lung and finally into the alveolar space, impairing gas exchange. Increased pulmonary vascular resistance describes pathophysiology of hypertension, pulmonary hypertension, increased pulmonary vascular tone, chronic hypoxia, venous thromboembolism disease, and left-sided heart failure are many mechanisms that increase pulmonary vascular resistance. It may be increased in asthma secondary to hypoxia, but it's not the primary mechanism for an asthma exacerbation. Okay, next.
Okay, uh, an 8-day old newborn is brought to the emergency department after she developed weakness and stopped breathing while being bottle fed. On arrival, she is intubated, stabilized. During stabilization, she has 3 minutes episodes of bicycling. She has 3 minutes episodes of bicycling movements of the lower extremity and deviation of the eyes to the left. Phenobarbital is administered. Her pulse is 160 per minute, respiration 42 per minute, blood pressure 60 by 40. Examination shows poor response to the stimulation and decreased muscle tone. Deep tendon reflex are brisk. Babinski sign is present bilaterally. Lumbar puncture is performed. CSF analysis show glucose 55, protein 65, erythrocyte count 350, leukocyte 70. um, Segmented neutrophil 20, lymphocyte 80%. Treatment antibiotic is begun. She is admitted to the ICU. Which of the following is the most likely causal organism?
It has blood.
Blood goes for herpes, isn't it?
Yeah.
But neonatal, if we think about neonatal meningitis,
Oh my God, I know what you're trying to say. No, this will be group B strep. We fell for that question somewhere before.
okay,
But blood,
blood
but
never goes for group B. I think so.
group B, I think so. Yeah,
Let's check.
yeah. We
Okay.
had the question before. What is the answer? Okay, it's herpes. Good. This, what is it? These newborns with seizures, lethargy, CSF with lymphocytosis, and increased red blood cells has presentation for encephalitis caused by HSV. Neonatal infection with HSV can occur via placenta or through direct inoculation as the newborn passes through the birth canal of a man with active lesions. Infection with HSV can cause both cutaneous herpetic lesions and systemic manifestations such as meningoencephalitis. Patients may present with abdomen status, headaches, fever, seizures, and focal neurologic deficit. A newborn lethargy may be the primary sign, presenting sign. Lumbar puncture should be done in all patients with suspected HSV encephalitis and often show mild increased protein, normal or mildly decreased glucose, increased red blood cells, and increased leukocyte with lymphocytic predominance. Definitive diagnosis PCR. Testing detect HSV in the CSF. Treatment intravenous cyclovir. It is not group B strep, are both common cause of neonatal meningitis. Patients may present with lethargy and seizure, but the CSF will contain decreased glucose, increased protein, leukocytosis with neutrophilic predominance. Okay, next.
A previously healthy 10-month-old boy is brought to the emergency department because of 3-day history of profuse watery diarrhea, frequent vomiting, and poor feeding. 3-day history of profuse watery diarrhea, frequent vomiting, and poor feeding. He usually breastfeeds well but refused all feedings today. Growth and development are appropriate for age. He appears lethargic. His pulse is 180 per minute, respiration 48 per minute, blood pressure 68 by 54. Examination shows mild abdominal distension, capillary refill 4 seconds. Which of the following is the most appropriate next step in the management?
Oh my God, I had a question like this.
Yes,
Saying that we give oral, but
but in here, like patients, look at the patient's blood pressure. It's very low. You cannot, and he
but
has
that was
frequent vomiting.
and that was the same thing. The question yesterday was like frequent vomiting, low blood pressure, and I was like, oh, it has to
But
be intervened.
capillary refill is high. Normal capillary refill is less than 3
Yeah,
seconds.
yeah, that was the same thing yesterday. Okay, I guess I'll give oral, but
But
I guess I'll give IV. Sorry, um,
I
but
think
I
that like in the U world there is a question like 20 ml per kg IV bolus fluid of normal saline. You have found this question?
normal side on the U. No, I don't remember. Okay, I know it's okay. Let's give him just IV of normal saline, I guess. Okay, let's check. Ready?
Yes.
Sorry, I'm gonna ask you. Yeah, IV of normal saline. This question yesterday, I feel like the answer was wrong. This infant with the recent GI illness has presentation consistent with dehydration. Dehydration categorized by mild, moderate, or severe based on the presenting signs and symptoms. Patients with mild dehydration will present with normal vital signs as well as normal mental status and urine output. Okay. normal signs, vital signs, and normal urine output. Patients with moderate to severe may present with tachycardia, tachypnea, hypotension, delayed capillary refill, lethargy, sinking, fontanelles, and decreased urine output. Patients with moderate to severe dehydration should receive an initial bolus of 20 cc/kg of intravenous crystalloids like normal saline or lactate drinkers for volume expansion. Patients with severe dehydration and hypovolemic shock can quickly decompensate and progress to cardiovascular collapse if not adequately resuscitation, and therefore should be frequently reevaluated with addition of fluid boluses given. Oral dehydration is appropriate in cases of mild dehydration in a child that is tolerating oral intake. This patient with vomiting for feeding and signs of more significant dehydration needs appropriate resuscitation with IV crystalloid. Continuous infusion of fluids at maintenance dose will be appropriate only after adequate volume resuscitation and euvolemia has been achieved. Okay. Okay.
Next, an 8-year-old girl. An 8-year-old girl is brought to the physician because of 6-day history of occasional headache, fatigue, poor appetite, occasional headache, fatigue, poor appetite, 2-day history of brown urine. She vomited yesterday morning, but has not had abdominal pain, diarrhea, but has not had abdominal pain, diarrhea, or painful urination. Her father reports that he had a sore throat and a fever for 2 weeks. He had a sore throat and fever for 2 weeks ago that resolved spontaneously. She has no history of serious illness, takes no medication. Her growth and development has been appropriate for age. She appears mildly pale but is no distress. She is at 50 percentile for height, 75%. She is at 50 percentile for height, 75 percentile for weight. Temperature is 36.7, pulse is 108 per minute, respiration is 16 per minute, blood pressure 138/88. Tonsils are enlarged, mildly erythematous. Tonsils are enlarged, mildly erythematous, but no exudate is present. The lungs are clear to auscultation. On cardiac examination, a grade 2 by 6 ejection systolic murmur is heard. A grade 2 by 6 ejection systolic murmur is heard. There is no rub or gallop. Abdominal examination shows no abnormalities. Extremities are warm. There is 1 plus edema. Lab studies show sodium 138, potassium slightly higher, chloride normal, bicarbonate is low, blood urea nitrogen high, creatinine normal, urine pH normal 5, specific gravity 1.020, blood is 2 plus, protein is 1 plus, RBC cast too numerous to count, and gram stain show no organism. Which of the following is the most appropriate next step in the diagnosis? November. Mm,
She has SLE. No, she has. Let me see. Tonsils, blah blah blah. Fatigue, occasional headache, vomiting. Let me check the serum C3, C4. Going to SLE. And she has edema. I know it's glomerulonephritis. Wait. Ah, I feel like we check ANA. No, no. Between A and B. Okay, let me
But
see.
two things should not be present. Is the all the features of the SLA matches, like
No,
there is no
there,
rash,
yeah, there is no rush. There is no. It doesn't really besides the urine thing, it doesn't really match easily. But
but RBC, you are thinking, but RBC cast, what's his blood pressure? Blood pressure
it's
is slightly higher, 138. Mm,
okay. Let's see what they say. Ready?
Does he have fever? No, not fever.
No, it's not. It's nothing bacterial. It's glomerulonephritis. We know that, but I just don't know if we should check the complement level or we should just check the.
We should check the complement level.
Oh,
Okay.
okay. Let's see.
In the PSGN, there may be hypocomplementing, as far I remember.
Acute PSGN is a type of
Isn't it?
nephritic syndrome. Yeah. Uh-huh. PSGN is a type of nephritic syndrome character. Yeah, because he had the pharyngitis. Has to be. Dark color urine hypertension, like AKI, hematuria, hematuria and proteinuria following an infection with group A straight. The pathogenesis of PSGN involves strep antigen complexing with antibodies, deposition of immune complexes in the glomerular basement membrane, and triggering of complement activation and inflammation. Live microscopy shows deposit of C3 and IgG in the glomerulus and mesangium. The deposition of C3 in the glomerulus and mesangium leads to decreased concentration of serum C3. The analysis shows hematuria and variable proteinuria with or without red blood cell cast. Um, Hypertension associated with PSGN is caused by salt and fluid retention, resulting in volume overload. Fluid retention can lead to generalized edema, periorbital, pretibial, and pedal edema. It can also lead to complication of heart failure, pulmonary edema, and respiratory distress. Next.
Okay. And an 18-month-old boy is brought to the emergency department because of 2-day history of increasingly rapid breathing and irritability. 2 months ago, he has he had a high-grade fever, pink eye, red swollen hands, high-grade fever, pink eye, red swollen hands, enlarged lymph node, cracked red lip. These symptoms resolved spontaneously within 14 days. He is in obvious discomfort. His temperature is 100.4, pulse 150 per minute, respiration 60 per minute, blood pressure 60 by 40. Examination shows no other abnormality. X-ray chest shows cardiomegaly. An ECG shows right axis deviation, left ventricular hypertrophy, ST depression in lead 2 to 3, lead 2 and 3, ST segment depression lead 2 and 3. Which of the following is the most likely mechanism of tachypnea? Right. Yes.
What happened? So is congestive heart failure. This patient prior illness and current presentation are highly concerning for congestive heart failure caused by Kawasaki disease. Kawasaki disease is a multisystem vasculitis in children characterized by fever for at least 5 days. Bilateral non-exudative conjunctivitis, polymorphous rash, lymphadenopathy, erythema, and edema of the hands and feet. Erythema affecting the mucous membrane with dry, cracked lips. The diagnosis of Kawasaki disease: fever for 5 days or more plus 4 of the remaining criteria are required. Lab studies may show thrombocytosis and increased ESR. Um, yeah, complication of Kawasaki disease include coronary artery aneurysms, and if untreated, can lead to aneurysm expansion, rupture, myocardial infarct, and congestive heart failure. Okay, therefore, children suspected with having Kawasaki require immediate evaluation with ECG and echo treatment and monitoring for progression and complications. Treatment of Kawasaki involves high dose aspirin and IV immunoglobulin. And it's the only widely accepted indication for aspirin use in febrile children due to the risk of Reye syndrome. Kawasaki disease is one of the most common pediatric vasculitis and a cause of pediatric heart disease. Next.
Okay. In Kawasaki disease, what type of myocarditis is seen?
Myocarditis.
I think that lymphocytic myocarditis.
Oh,
There is one question in the UL.
oh, I didn't know that.
Okay. A 12-year-old boy is brought to the office because of 2-day history of severe bilateral cuff pain. Severe bilateral cuff pain. 1 week ago, he had a dry cough, sore throat, headache, dry cough, sore throat, headache, fever, which resolves with ibuprofen therapy after 5 days. Currently, he is not taking any medication. Temperature is 37. Examination shows marked tenderness to palpation. Marked tenderness to palpation of the cuffs. Which of the following is the most likely diagnosis?
Hmm,
Tenderness.
I do not know. Sore throat. If it's rheumatic fever, it would be the nodules, the arthritis. What was the other one? Jones. Arthritis, nodules, erythema, something. Probably not that. Ready?
Yes. What you have picked?
Pick the influenza, but I don't think it's that.
Okay.
I was between maybe rheumatic and I was between a lot of them. I ain't gonna lie. So it's the influenza. Okay. Influenza-induced myositis is a common cause of viral-induced myositis. The first time I heard that, and triggered by influenza A or B. Most patients report associated viral symptoms such as fever, anorexia, arthralgia. Myositis may occur during active infection or after the infection, and symptoms include myalgias and tenderness. Additional symptoms range from mild weakness to quadriparesis. Okay, in addition to rhabdomyolysis, lab analysis may show increased CK activity in addition to myoglobinuria. Testing for influenza virus is diagnostic for influenza-induced myositis in the setting of appropriate signs and symptoms plus additional supporting lab measures. Not dermatomyositis present with cutaneous and MSK manifestations. Cutaneous findings include heliotrope rash, scrotum papules overlying the joints and the hands, rash in a shawl distribution. Muscular MSK findings include proximal muscle weakness in the upper and lower extremities. Diagnosis is made by combination of clinical findings and serologic testing included. Any antibody, Jo-1, anti-SRP, anti-MI antibodies. Patient diagnosed with dermatitis should undergo further workup, including age-appropriate cancer screening to rule out malignancy. It is not D or E. Rheumatic fever is a sequela of group A strep infection in which there is an autoimmune reaction against host protein that have similar structure to strep M protein. Its manifestations include carditis, arthritis, cutaneous erythema, melanosis, and chorea. Parvo B19 may be associated with acute arthritis and arthralgia. In absence or presence of the classic pink patches on the bilateral cheeks of um, children, given an appearance of lap cheek. Joint symptoms are often acute, symmetric, and associated with the smaller joints of the hands, wrists, and feet. The symptoms typically resolve within 3 weeks following the diagnosis. Okay. Okay. Next.
A 12-month-old girl is scheduled for discharge 7 days after admission to the hospital for treatment of bacterial pneumonia. She has responded well to the treatment with IV antibiotics. This is her third admission to the hospital for treatment of bacterial pneumonia. Uh, During the past 9 months, she has received no immunization. Examination shows no abnormality. Serum studies show decreased T lymphocyte function. Additional serum studies show IgA 50 normal, IgG normal, IgM normal. CD4 count is low. CD4 T cell count is low. Which of the following vaccine should be administered at this time?
Don't know. Okay.
T cell count is low.
So
So
is it what virus or
T
well?
cell
B is for bacteria and what? And C is
fungus and T cell is for
virus, right?
virus.
So we know it's not influenza for sure. It can be BCG is for the tuberculosis. But tuberculosis is bacteria, so it cannot be that. Between virus, rotavirus, and varicella, I'm thinking.
Rotavirus is usually given within 1 year.
But she
Mm,
says she has not received. Oh, she has
but
received no immunization.
rotavirus is not a routine vaccine, isn't it?
It is. I thought it was routine. It's not.
Sorry.
I thought yes, it was routine. Or is it? It's not. I thought yes, it's routine.
Okay, maybe.
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 Let's check. Oh my God,
No vaccine.
hemophilus. I, I don't even know what to say. Anyway, T lymphocyte function is essential component of host defense and is impaired in this patient needed to recurrent bacteria. Oh, that's true. He was getting bacterial infection. Haemophilus influenza type B is an encapsulated gram-negative bacterium that can result in various mucosal infections such as conjunctivitis, otitis media, bronchitis, pneumonia. It was the leading cause of pneumoconiosis in children prior to widespread immunization. The Haemophilus influenza vaccination uses conjugate capsular polysaccharide to whatever. Vaccination is a form of active immunity designed to prevent disease by stimulating the immune system to develop and maintain the ability to respond to foreign antigen. In a patient with recurrent bacterial pneumonia, a vaccine against Haemophilus influenza should be administered as it is a frequent cause of bacterial pneumonia. It's not rotavirus double-stranded RNA virus that causes infectious diarrhea in children, and it does not cause bacterial pneumonia. Thus, a vaccine against Haemophilus is a higher priority for a patient with recurrent bacterial pneumonia. The defense against varicella relies on T lymphocyte function, which is impaired in the setting of this patient. Infants with deficient T lymphocyte are at increased risk for severe infection with bacteria, with varicella. A vaccination against hemophilus is a higher priority for a patient with recurrent bacterial infection. Okay, so we were not wrong. It's just that the question specifically said that he kept having bacterial pneumonia. Yeah.
Sorry, can you explain?
No, I'm saying that we were not wrong, but the question specifically kept saying the child has bacterial pneumonia, bacterial. So the
Yeah,
question emphasizes bacterial, yeah.
if they are saying about bacterial pneumonia.
And the only thing in the answer choices that causes bacterial pneumonia is Thermophilus.
Pneumonia.
Rotavirus doesn't cause, varicella doesn't cause. Yes, that was the key there.
Okay, a 5-year-old girl is brought to the clinic by her mother because of 5-day history of progressive burning with urination and redness in the vaginal area. Her mother also noticed a small amount of yellow discharge on the patient's underwear. The patient has not had fever, vomiting, diarrhea. She has no history of serious illness, receives no medication. There is no history of sexual abuse. Vital signs are within normal limits. Genitourinary examination shows moderate erythema over the vagina and entire perineum, including the perianal area. No vesicles or pustules are noted. There is small amount of white discharge at the introitus. The remainder of the examination shows no abnormality. Results of culture of the vaginal discharge are pending. Which of the following is most appropriate pharmacotherapy? Results of a culture, the vaginal discharge are pending. Which of the following is the most appropriate pharmacotherapy?
Ready?
Is it fungal infection?
Mm, I want to see a candida. I was thinking candida, but mm, don't know.
White discharge at the introitus.
Mm, it's weird.
Ready?
White discharge. Yeah. It's topicalness. I guess it's candida. This pediatric patient with vulvar redness, white discharge, likely has vulvovaginitis. Candida is a fungal pathogen that causes a variety of infection, including vulvovaginitis, urethritis, and sepsis. Patients with vulvar may present with erythematous rash, vaginal itching, and thick white discharge. Examination is characterized by thick white coarse discharge, and diagnosis is via pseudohyphae or microscopy. Common risk factors include diabetes, recent antibiotic or steroid use. Treatment superficial candidiasis infection is with topical antifungal such as nystatin. Nystatin. Okay, next.
What is your diagnosis?
Oh, did you read it?
24, sorry,
Oh,
23.
22. 22. I was
I
like, wait,
I
what is
have
the.
I have got 24.
I'm like, wait, I didn't hear you reading it.
Okay, sorry.
22.
Uh,
No.
A previously healthy 7-year-old boy is brought to the physician by his mother because of 5-day history of runny nose and mild cough. His mother says his nasal discharge was clear. His mother says that his nasal discharge was clear at first but has been yellow for 24 hours. He had a low-grade fever for the first 2 days of illness but has not had fever for 3 days. The patient's father recently had a cold. The patient is at 50 percentile for height and weight. Temperature is 36. Pulse is 100 per minute. Respiration 24 per minute. BP 96 by 62. Examination shows moderate amount of to white discharge from both nostrils. There is no periorbital edema and erythema multiple 1.5 cm freely mobile non-tender nodule are palpated in the anterior cervical area bilaterally. The remainder of the examination show no abnormality. Which of the following is the most likely diagnosis? Okay,
Material.
ready?
One moment. Yes, ready. So it is viral rhinosinusitis. This patient with rhinorrhea, mild cough, and low-grade fever and bilateral cervical adenopathy has presentation consistent with viral rhinosinusitis. Acute rhinosinusitis (ARS) is defined as symptomatic inflammation of the sinuses and nasal cavity lasting less than 4 weeks and can be classified as either viral or bacterial. Most cases of ARS are viral in cause with rhinovirus, influenza and parainfluenza virus being the most common bugs. Patients with viral rhinovirus may present with cough, nasal congestion, clear or purulent nasal discharge, and facial pain that is worse when leaning forward. In viral rhinosinusitis, fever is present, typically resolves within like 1 or 2 days. Physical exam may show tenderness to percussion over the sinuses. Treatment of viral rhinosinusitis involves supportive care with over-the-counter analgesic antipyretics, saline nasal spray, and oral or intranasal descongestant. Antibiotics are not indicated unless bacterial infection is suspected. This non-bacterial sinusitis has signs and symptoms that overlap with those of viral rhinosinusitis, and the two can be difficult to distinguish. Bacterial sinusitis is less common than viral sinusitis, and symptoms typically last more than 10 days. Symptoms typically present following viral upper respiratory infection, and patients may present with worsening of symptoms following an initial period of improvement. This patient with mild symptoms and fever that resolve after 2 days may most likely has viral infection.
Why it is not cervical lymphadenitis?
Oh, sorry. Cervical lymphadenitis present with enlarged, inflamed, and tender lymph nodes in the neck and may be either unilateral or bilateral. Bilateral cervical lymphadenitis often occurs secondary to viral upper respiratory infection, while unilateral cervical lymphadenitis is often bacterial. These patient lymph nodes are not tender.
Okay. An asymptomatic 17-year-old boy comes to the physician for a routine examination prior to the school sports. Examination shows no abnormality except for approximately 10 light Brown, hyperpigmented lesion over the trunk and the extremity. The lesions vary in size, 0.6 to 2 centimeter in diameter. There are some freckle-like lesions over both axilla compared to the general population. The patient is increased risk of each of the following.
Ready?
Wait 1 second. Is it neurofibromatosis?
Kind of. Wait, is it neuro? I don't. I
Or
don't know the.
tuberous sclerosis?
I don't know the diagnosis, but it sounds like the one with the glioma, but I don't remember the name.
Cutaneous neurofibroma, intellectual disability, leash nodule, optic glioma, pheochromocytoma, then a neurofibromatosis cyclops. Okay, let's see.
It's up to okay, so it's NF1, neurofibromatous 1. It's an autosomal dominant neurocutaneous disorder that typically results from an inherited mutation of the NF1 tumor suppressor gene on chromosome 17. NF1 is inherited with complete
Okay,
penetration
leave
by.
it
No,
because
I want.
okay, read because how much we read, the problem is there.
Lead to mutation in the NF1 gene occurs sporadically. NF1 present with cutaneous neurofibromas, benign neoplasm derived from neurocorrect cell, plexiform neurofibromas, hyperpigmented macules, axillary or inguinal, freckling, pigmented iris, hamartomas, Lynch nodules, cognitive disability and seizure. Patients with NF1 are at increased risk for optic nerve glioma and pheochromocytoma. Optic nerve gliomas are typically indolent lesions and are more frequently low-grade pilocytic astrocytoma. The lesion may involve one or both optic nerve of the optic chiasm or the optic chiasm. Affected patients present with insidious vision loss, proptosis, and optic nerve atrophy. The diagnosis of NF1 is typically based on physical exam findings, but genetic testing may be used to confirm. Treatment includes surgical debulking of tumors, management of seizures and neurologic complications, and genetic counseling. Management of optic glioma is controversial and may involve a combination of chemo, radiation, and surgical excision. Children with NF1 should undergo regular screening exam, included ophthalmic exam, at least annually to facilitate early detection and treatment of optic nerve glioma. Wait, it's not cerebral aneurysm is important cause of intracranial hemorrhage in adult, but it's not associated with anyone. AV malformation is characteristic of phacomatosis. Oh. Weber-Masson syndrome, also known as Bonnet, never heard those one. Syndrome, Weber-Masson syndrome, or Bonnet-Deschamps, whatever, presents with IV malformations of the retina, midbrain, as well as facial cutaneous angiomas. Hmm, okay,
Okay,
next. That's why you were asking me what's the most appropriate pharmacotherapy. Um,
I made mistakes in these three, like tuberous sclerosis, neurofibromatosis, and Starch Weber. Okay, tell me your diagnosis. Just look at the picture.
oh my God.
It is possible.
It is possible. Is it tinea, one of the tinias?
Yes, I
Okay,
think so. Isn't
okay.
it?
I mean, you told me to guess. I'm just guessing. I'm just guessing. Yes, it must be. What is it in the arm? So it's probably gonna be topical.
But
So
only
is it
topical can improve tinea. That's the
wait
thing I am concerned.
what? Because oral is only in the head, but here the lesion I'm thinking is in the arm, right? Malpuritic lesion. So thinking it's the arm. Wait, pleuritic. Hmm. Okay, fine. I'm not gonna overthink it. Let me just go with. I'm not gonna overthink it. I'm not gonna overthink.
I think that oral itraconazole can be the answer. Okay,
Can be
let's
the
see.
say.
Maybe you
Uh,
are right.
yeah, oral is only on the head. Topical cotrimazole. Topical cotrimazole and other azole antibiotics are commonly used to treat superficial dermatophyte infections, including tinea corporis. Tinea corporis, commonly caused by Trichophyton species and results from direct inoculation from the affected individual or animal, including dogs and cats. Microscopic exam of skin scraping with
Like for
KOH.
tinea capitis for hair, oral,
Mhm.
and
Um,
rest of the topical,
yeah, well, I thought that Divine said oral for head and feet.
head and
And
feet.
yeah, like head and I think it was the foot
Tinea
one. The
pedis
I think so, yeah.
or
Oh no,
onychomycosis.
wait. I think it was onychomycosis. But then my tutor said no, oral is only for the head. So at this point, I don't know.
Okay,
But I know for sure that for the head is oral. Now for the feet, I don't know. Like I don't think we found the question of it. So I don't
okay,
know. But yeah. Scrapings, microscopic exam of skin scrapings with KOH preparation shows brain branching septal hyphae. Tinea corporis is treated with topical azole, including cotimazole, which whatever we know. It's not mifurocin used in the treatment of superficial bacterial infections such as Staph aureus. Mifurocin, okay, and it's not oral. Let me see what it says with oral.
it is for
Oral,
impetigo, I think so. The topical mupirocin.
oral impetigo, yes, good. Oral itraconazole is a nasal antifungal with similar mechanism with topical cotrimazole. Because of the risk for side effects such as congestive heart failure and liver toxicity, itraconazole is often reserved to treat systemic infections such as blastomycosis, histoplasma, whatever. Additionally, azole antifungals agents may be used in caution as they inhibit. Okay, they didn't really answer our questions here. But yeah, they say itraconazole for systemic infections, I guess.
Okay, final question 25. A 3-year-old girl is brought to the office for follow-up examination. She has a seizure and strabismus. Seizure and strabismus. Her only medication is valproic acid. She is at 25 percentile for height and weight and third percentile for head circumference. She appears happy and has excitable demeanor. Frequently smiles and laughs. Examination show flat and posterior aspect of the head, prominent jaw, widely spaced teeth. She flaps her hand repeatedly. She has a stiff-legged gait, cannot climb stairs without assistance. Uh, Her attention span is short. She uses some gestures and sounds to communicate, but has not spoken any words. Which of the following is the most likely genetic defect?
Just a
It's
happy baby.
yes, it's Angelman, happy puppet.
Yeah. Mhm. Ready?
Yes, is it B?
Yeah.
Okay,
Angelman syndrome, uh, genetic disorder caused by microdeletion maternally inherited chromosome 15, which contains the gene for the ubiquitin pathway UB3A. Angelman syndrome is characterized by abnormal development of particular areas of the brain, like hippocampus, cortex, and cerebellum, in which the paternally inherited copy UBE3A is inactivated through imprinting, an epigenetic process involving selective gene blah, 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 thus creating a reliance on the maternally inherited copy for normal development. In contrast, microdeletion of paternally inherited UBE3A leads to different clinical presentation of Prader-Willi syndrome. I don't understand this. Children with Angelman syndrome present with characteristic signs and symptoms, including severe developmental delay, seizure attacks, speech delay, and microcephaly. Patients typically also display a happy, excitable demeanor and uncontrolled laughter and repetitive hand flapping movements. Other findings may include characteristic facial features like flat posterior aspect of the head, prominent mandible with widely spaced teeth and protruding tongue, strabismus, lip, and blah, 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 blah. Notable fascination with water. Oh, okay. That's
okay.
it. That's
Okay,
it. Let's see.
okay, that's
Guten
all
Morgen.
for